myself Dr. Priyanka, and I am one of the mentors for Study Medic, that is Study EBCOG. So today evening I will be presenting about an important topic which is important at the exam point of view. That is the obstetric emergencies, two obstetric emergencies, the shoulder dystocia and eclampsia. So do subscribe Study Medic and like and share important videos, and also press the bell button icon so that whenever any new video uploads, so you will get the notification. So without any delay, so I will start. So do remember that a little progress each day adds up to big results. So first we'll be discussing about shoulder dystocia, what shoulder dystocia is. So, shoulder dystocia is defined as if there is in the vaginal cephalic delivery that requires additional obstetric maneuvers to deliver the fetus after the head has been delivered. So, the head delivers spontaneously, and there is no problem in delivering the head. And after the head has been delivered, and there is difficulty in delivering the shoulders, even after the gentle traction has been applied. So how can we diagnose the shoulder dystocia objectively? So when there is prolonged head to body delivery time that is more than 1 minute, that is 60 seconds. So if it is more than 60 seconds, we will diagnose it as a shoulder dystocia. So what is the incidence of shoulder dystocia? So it is around 1 in 200, that is, it is around 0.5 to 0.7%. So shoulder dystocia, again, it is associated with many maternal and fetal complications, like maternal complications like the risk of postpartum hemorrhage in 11% of the cases. Also, sometimes it is associated with third and fourth degree perineal tears, that is obstetric anal sphincter injuries in 3.8%. And sometimes brachial plexus injuries, the incidence is varied. It is around 2 to 16%. And also the brachial plexus injury causing the permanent neurological dysfunction in 10%, in less than 10%. So when the patient is diabetic, the risk is increased 2 to 4-fold. Why it is especially increased in diabetics is because that in diabetes there is hyperinsulinemia, and the increased insulin is more prone for deposition of fat around the shoulders, and hence there is difficulty in delivering of the shoulders, and hence shoulder dystocia. So that is the risk factor. So what are the risk factors? Other risk factors for developing shoulder dystocia is the most important. It is divided into two classes, that is the pre-labor and intrapartum. So what are the pre-labor causes? So having a history of previous shoulder dystocia is the most important major risk factor for developing shoulder dystocia. It carries a tenfold increased risk of developing shoulder dystocia in current pregnancy if there is a history of shoulder dystocia. So if there is a macrosomia, meaning that the estimated fetal weight is more than 4.5 kilograms, and especially if the mother is diabetic, so that also increases the risk of shoulder dystocia. Other risk factors include having a high maternal BMI, especially more than or equal to 30 kilograms per meter square. And also if the labor is induced, so that also increases the risk of shoulder dystocia. So what are the intrapartum risk factors? So we usually anticipate shoulder dystocia when there is prolonged first stage of labor, or if there is secondary arrest, if the labor was progressing well, but then there is secondary arrest afterwards in the progress of labor, or if there is a prolonged second stage of labor, or if the labor is induced or augmented with oxytocin, that also increases the risk of shoulder dystocia. And also doing instrumental deliveries like forceps and vacuum will also increase the risk of shoulder dystocia. So having a spontaneous vaginal delivery carries the lesser risk of developing shoulder dystocia. So can we predict shoulder dystocia? So the guideline, RCOG guideline says that, it is very difficult to predict shoulder dystocia, but we should take, each patient should be customized, and their risk factors should be taken into account. So whatever the risk factors we have seen, so that should be taken into account, and then the risk of possibility of shoulder dystocia should be determined. Okay. So usually, if there is a if the following factors are there, if there is a prolonged first stage of or second stage of labor, then the shoulder dystocia should be anticipated. Meaning that we should always anticipate shoulder dystocia if the patient is high risk. Okay. So what are there are few important points. So does the induction of labor help if there is a macrosomic baby, meaning that if the baby is more than 4.5 kilos? So the guideline recommends that there is no benefit if there is induction of labor done for a macrosomia, but in a non-diabetic woman. Okay. So, but those who are having macrosomic baby that is more than 4.5 kilograms and plus if they are gestational, history of gestational diabetes is there, for in them, the induction of labor at term can reduce the incidence of shoulder dystocia. Okay, so there are certain recommendations for doing an elective cesarean section also. So elective cesarean section is recommended when the estimated fetal weight is more than 4.5 kilos in a macrosomic fetus in a diabetic patient. So in that case, an elective cesarean section is recommended. And those who are not diabetic, so in them, if the estimated fetal weight is more than 5 kilograms, then an elective cesarean section is recommended. So what to do when you diagnose a case of a shoulder dystocia? So whenever there is an obstetric emergency, whether it's a shoulder dystocia or a postpartum hemorrhage, or if there is a eclampsia, so where any emergency, so first most important thing to do is to call for help. So all the important MDT, that is the senior obstetrician, should be informed, the anesthesiologist, the midwife coordinator, the additional midwife, and also the neonatologist should also be informed about that there is a shoulder dystocia in the labor room. So then the second most important step is to also call the scribbler, so that documentation is very important in case of shoulder dystocia, where the all the according to the timings, the steps when the steps are done, it is mentioned according to the timings for the medical legal purpose. So then also an assistant are needed to do the additional maneuvers. Okay. So then the next step is to discourage any pushing. So if the mother is pushing, so we will encourage her to, we'll discourage her to push, and then we will make her lie flat and also move her buttocks to the edge of the table. If there is any oxytocin going on, so we will stop that oxytocin. Also, if there is any fundal pressure that has been given, so that also should be avoided, because that will again worsen the shoulders, and the shoulders will get impacted more, and again it will worsen the condition. So after calling for help, then what is the next step which should be done is the McRoberts maneuver. So here it is also called as thighs to abdomen. So here this is the McRoberts maneuver. So when we bring the patient's buttocks to the edge of the table, we abduct and hyperflex the patient's hip, and we abduct. Okay, so abduct and also hyperflex. Why this is done? So the shoulder dystocia happens due to not soft tissue but due to bony impaction. So what this McRoberts maneuver does is it straightens the lumbosacral angle, and also it increases the anteroposterior diameter, which is usually decreased in case of shoulder dystocia. So it increases the anteroposterior diameter, and which facilitates the delivery of the anterior shoulder. So this is the first one, is the McRoberts maneuver. So McRoberts maneuver alone, if done in shoulder dystocia, it is successful in up to 90% of the cases. So that is done first. And the second maneuver which should be done is the suprapubic pressure. So here in figure 2, suprapubic pressure is given. So here from the fist of the hand, so it is on the posterior part of the anterior shoulder, the suprapubic pressure is given. So what it will do is it will dislodge the anterior shoulder which is impacted. So sometimes the McRoberts and suprapubic maneuver are simultaneously tried, and routine axial traction is given. So that will help in relieving the shoulder dystocia. And giving any fundal pressure should be avoided. So what is the consideration about episiotomy? So episiotomy, the guidelines says that it is not routinely recommended, but it will have sometimes it is considered in cases of shoulder dystocia, because it won't relieve any bony impaction. It won't create any increased space for as a bony impaction, but it will at least increase the space to do any further maneuvers for which the insertion of hand is required. So it will create room. So what is the next step is giving an episiotomy, and after that either we can deliver the posterior arm if the anterior shoulder is unable to deliver, or we can do the internal rotational maneuvers. So what is the main aim of this delivery of the internal posterior arm? Is the posterior arm is easy to deliver than the anterior arm. And in internal rotational maneuvers like Rubin's maneuver or corkscrew maneuver, so the hand is kept like a corkscrew, like the hand is kept on the posterior part of the anterior shoulder and the anterior part of the posterior shoulder, and it is moved like a corkscrew. And then when the posterior shoulder comes at the position of the anterior shoulder, and it is easy to deliver. So this is the main aim of these maneuvers. So after these maneuvers are failed, so then is the time that the consultant obstetrician and anesthetist should be informed again. Okay. And then if all these maneuvers are failed, and then again, and all four positions should be tried, where the position where the patient uh, keeps her both the hands and the knees on the floor, and then on all fours, and then the baby is delivered. So that will also increase the anterior posterior diameter. So even if this all the things fail, so again what we can do is can repeat all the procedures again, starting from the McRoberts manual, or the last resort is to doing a cledotomy. So cledotomy is to doing the fracture of the clavicle, or a Zavanelli maneuver. So Zavanelli maneuver is when again the fetal head is repositioned inside the uterus, and then the patient is shifted emergency to the operation theater, and the baby is delivered by the cesarean section. Or a symphysiotomy is done, where there is a division of the pubic symphysis is done. But these are rarely done nowadays. So usually the if the management is failed, again the procedure is repeated by doing the McRoberts manual. So what to do after the baby is delivered? So as I said, the documenting is very important in these cases. So the scribbler should document all the steps and the timings that were at that time they were done. And after that, after delivery of the fetus, the baby should be handed to the neonatologist, especially the senior neonatologist, and the baby should be looked for any signs of birth asphyxia, and also look for any injuries, especially clavicular injuries, or any signs of brachial plexus injuries, or any fractures. So and also most important thing is to look to send the blood samples, paired cord blood gases for the baby. In case of shoulder dystocia, this is very important to check the acid-base balance, acid-base status of the baby. So paired cord blood sample should be sent. So this is the fetal part, and the baby will be managed by the neonatologist. So what about the also the blood sugar values should be done for the babies, as these are mostly the shoulder dystocia cases are born to the diabetic mothers. So sugar monitoring should also be done. So what about maternal management? So again, shoulder dystocia carries the maternal risks, like increased risk of perineal tears, especially the OASS, that is obstructive anal sphincter injuries, third and fourth degree perineal tears. And also there is increased risk of postpartum hemorrhage that we saw around 11%. So here a proper inspection of the genital tract should be done to look for any tears or any bleeders from the vagina or cervix, any cervical tears, and if any present should be managed accordingly. And also carefully washed for the bleeding. So bleeding should be, blood loss should be estimated, and depending upon that, management should be done. So Yeah, after the patient, also the monitoring should be done for the and also antibiotics and analgesics, and also input output should be charted. And the most important thing is to do the incident reporting. So any case of shoulder dystocia and reporting performer should be filled up. So this is the shoulder dystocia documentation form, where we have to write the date and the time of diagnosis of shoulder dystocia, and the person who is completing the form, and the signature, the mother's name, date of birth, and hospital number, and the consultant under care. So when the call, it is all the written by the scribbler. So when was the help called, at what time, and when was the emergency call was given. So everything. So who all were present, who all MDT were present, and what were they doing. When was the manures performed, when was the microbites manure performed, by whom performed, and again the orders, like how many times it was performed. So everything should be mentioned. Okay, and again the paired cord blood samples, what were the results, and also the birth weight of the baby. So everything should be mentioned in this. Okay, so this is an important documentation forms that should be filled. So that's why shoulder dystocia managing is very important, and skills and drills are also are there in the hospital management protocol for managing shoulder dystocia cases. So this was about shoulder dystocia. Now coming to the second topic, that is eclampsia. So what is, first of all, preeclampsia? Preeclampsia is, it is a multisystemic disorder, meaning that it affects many organs like renal, liver, or blood levels, or cerebral. Okay, so it is a multi-system disorder, and it is characterized by high development of hypertension, and also involvement of one or more of the organ systems, that is the maternal part, and or if there is a fetal part involved, that is there is fetal growth restriction. So here, previously, the proteinuria was also the criteria to make a diagnosis of preeclampsia, but nowadays the proteinuria is no longer considered mandatory to make the clinical diagnosis. So how a preeclampsia should be diagnosed? So as we know that gestational hypertension is when the blood pressure is more than 140/90, and it develops after 20 weeks of gestation. It is called as gestational hypertension. So what is preeclampsia? So preeclampsia is when it is the gestational hypertension, when the blood pressure is more than 140/90 after 20 weeks, and plus there is a new onset damage to the multisystemic disorder. That is, if there is a proteinuria, what we call it as significant proteinuria, when it is more than 300 milligrams per 24 hours, or if the creatinine is more than 1.1 milligrams per deciliter, or if there is thrombocytopenia, the platelets are less than 1 lakh into 10 raised to 9, or if there is elevated liver enzymes, the AST and ALT, and also if there is pulmonary edema, that is the fluid shift, and also if there are cerebral and visual symptoms. So any of these, and plus with the gestational hypertension or the fetal growth restriction, can label it as a preeclampsia. So what does HELP syndrome consist of? So HELP means H is hemolysis, EL is elevated liver enzymes, and low platelets. Okay. So what is eclampsia then? So eclampsia is the combination of the preeclampsia in a patient who is having a preeclampsia and having a grand mal seizure. So any fit in a preeclamptic patient is considered as the patient is having as eclampsia. So it is an obstetric emergency. And again, when the patient is has a grand mal seizure, so the first important step is to call for help again, and to call for the senior obstetrician, the anesthesiologist, the neonatologist, the senior midwife, and also other helping hands should be called. And also the scribbler should be there for documentation of the events. So what should be the management? So here there are many things that needs to be managed. So first is to manage the emergency, that is the patient is having a seizure and is not able to breathe properly. So that is the most important, that is to give the supportive care. Then as we know that they are having a preeclampsia, that is that due to raised blood pressure, so we need to control the blood pressure. And also they are having fits, so that is to control the convulsions by giving anticonvulsants. So these are all given simultaneously. So what is the first step that needs to be done is to support the airway. Okay, so always first initial step is to support the airway. How to do that? To give the left lateral position for the patient, and if the patient is moving, so to put on the rails of the cot, and also put the patient in the dark and quiet room. And the oxygen is given through face masks at the rate of 10 liters. And also circulation should be sited by starting an IV line, okay, preferably a large bore IV line. But the the dose of the fluid overload should be avoided in case of eclampsia, and the regular 125 ml per hour dose should be avoided. So the infusion rate should be 80 ml per hour in cases of eclampsia or cardiac disease, for example anemia. And also the input output charting should be monitored by the urinary placing a urinary catheter. And simultaneously investigations should be sent. So what all investigation should be sent is the proper complete blood count, also to know if there is any low platelet count, if there is any anemia, that is any also to rule out HELP syndrome, any hemolysis signs, any low platelets. And also liver function tests, so to look for any elevated liver function, liver enzymes. In also renal function tests to look for any elevated level of creatinine. And also coagulation profile, because these patients are at increased risk of developing going into DIC. So sending a coagulation profile is also most important. And urine for proteins. So then the next important step in the management is to control the seizures. Okay, so the patient is fitting. So to control the seizures, the drug, or the first line gold standard drug of choice in the management of eclampsia, is to administer magnesium sulfate. So magnesium sulfate, how it is given is the loading dose and the maintenance dose. So loading dose is given as 4 gram over 5 minutes, IV 4 gram over 5 minutes. And then afterwards, then infusion is started for 1 to 2 gram per hour for 24 hours for delivery, whichever is sooner. So this is the dose for magnesium sulfate. So if you are giving magnesium sulfate, usually the magnesium levels are not recommended by the guideline, especially. But if there is any case of any renal dysfunction case, so in those cases the magnesium level should be monitored, because of increased risk of toxicity. So what all should be monitored if the patient is been receiving magnesium? So the deep tendon reflexes, especially the patellar reflexes, should be checked every 4 hourly. And also the respiratory rate, it should be minimum 12. And also the urine output. So the urine output, so catheter should be placed also to look for the urinary output. So after giving this anticonvulsants, so if the patient stabilizes, then it is fine. But if we have to stabilize the mother first, and if the patient is less than 34 weeks, then giving corticosteroids is considered to anticipate, because of anticipation of delivery. And when the mother stabilizes, then the further management of delivery should be tried. So depending, the management and mode of delivery will depend upon the Bishop score and also the proper clinical situation. So if the patient is having recurrent seizures again, so what is the dose? It is the again a 2 gram of magnesium sulfate bolus IV is given over 5 minutes. But if there are persistent seizures, then we can also administer lorazepam in the dose of 2 to 4 milligram IV or diazepam 5 to 10 milligram IV, or phenytoin 15 to 20 milligram per kg IV. So then the next management is to control her blood pressure. So all this should be done simultaneously. So the main agent of choice for controlling the blood pressure is the labetalol. So the labetalol IV is preferred. So giving 20 milligrams IV over 2 minutes, and also then for giving the bolus and the infusion. So the main contraindication for giving the labetalol is the asthma, as it is a beta blocker. So in that cases, the second line agents like hydralazine can be given, or sometimes nifedipine can be given. So nifedipine also, if given, can be given as a 10 milligram oral dose, and maximum it is up to 40 milligram. So it differs according to guidelines. Some guidelines say 90, some guidelines say 120 milligrams. So it should be given nifedipine, but always remember that sublingual administration of nifedipine should be avoided. Okay, so because it can cause sudden hypotension and also tachycardia. So sublingual administration is contraindicated. And also, uh, if we are using concomitant nifedipine and also magnesium sulfate, so caution should be used. The guideline does not say that it is contraindicated, but it should be usually avoided. But in case if it is needed, so caution should be taken, as both can cause sudden hypotension. Okay. So then what to do after so after giving, the patient is been stabilized. So if the mother is not stabilized, so till then delivery is not, it is inappropriate, and all again it will worsen the mother's status. So once the patient is stabilized on antihypertensives and she is on anticonvulsants, and her airway is supported, then the MDT can decide about delivering her. Okay. So in the absence of convulsions, prolonging the pregnancy may be possible sometimes if there are no convulsions to improve the outcome for the premature fetus. But the criteria should be the mother should be hemodynamically stable. And in these cases, continuous close monitoring of mother and baby is needed, like admitting the patient. So what to do if the patient is if the baby is less than 34 weeks of gestation? So steroids should be given. So even if the delivery is anticipated early, still the guideline says that steroids should be given, because the benefit of steroids, even if it is between 48 hours to 6 days. However, even if the delivery is planned within 24 hours, it may still be of some benefit than not giving at all. So steroids are recommended if the period of gestation is less than 34 weeks. The mode of delivery, if it is less than 34 weeks, so the guidelines says that induction of labor, if the Bishop's score is poor, the induction of labor will be unlikely to be successful. And if the patient is not in labor, so consideration can be given by doing a cesarean section. So if the patient is more than 34 weeks, vaginal delivery can be tried. If the Bishop's score is good, the patient is hemodynamically stable, and all the criteria is met, that is the fetus is in cephalic presentation with adequate growth. So in that case, a vaginal delivery can be tried. So what is important patient safety point here? Whenever the baby is delivered, during the third stage, what we usually give as for 5 units of internal IV syntocinon, oxytocin should be given, but ergometrin or symptometrin should be avoided, as it increases the blood pressure. So it is contraindicated in patients with hypertension. So ergometrin should be avoided. So what is the postnatal management after the patient of eclampsia is delivered is to, again, the maternal and fetal management. So mother should be admitted usually after the eclampsia in the HDU, high dependency unit, and her vitals should be charted on the Muse chart, and then output should be monitored, and she should receive proper analgesics and uh, antibiotics, and also thromboprophylaxis. VT risk assessment should be done for her, and depending upon that, and either anti-embolism stockings, or she should be if allowed to take oral hydration, and also ambulation, if it is not contraindicated, should be advised. Again, blood parameters should be sent to look for her any developing any anemia, or about her liver enzymes, or how is the platelet count. And also four hourly blood pressure measurements should be done. So what about her antihypertensives, her blood pressure control? So the guidelines is that all the antihypertensives are safe in the postnatal period. Even the AC inhibitors like captopril and enalapril, they are safe. But but methyl dopa should be avoided because it is especially from day 2 because it is known to cause postnatal depression. So that is avoided. And also diuretics are usually avoided in breastfeeding women. So if the blood pressure comes at 130 by 80, then we can aim to reduce the treatment. And if it comes to less than 120 by 70, we can stop the treatment. Again, while the discharging the patient should be explained about the red flag symptoms, that if there is sudden onset of any blurring of vision or clonus, or if there is any headache or disturbance in the vision or palpitations. So in that cases, so she or any flashing of lights. So in that cases, she needs to report to the hospital emergency. In emergency, an emergency contact number should be given to the patient. And also all the things like even in shoulder dystocia or eclampsia, whatever the events have been happened have should be communicated to her local general practitioner and also the midwife. So via written information preferred. So she should have a hospital appointment within 12 weeks of delivery where her blood pressure and proteins in urine should be checked, and also her risk should be explained of developing again severe preeclampsia in or eclampsia in the next pregnancies, or developing of again monitoring of the blood pressure in her is very important. So that was all for the shoulder dystocia and eclampsia. So thank you so much for watching the video, and I hope this will definitely help in your exam preparation. And thank you so much, and good luck for your exam. Anusha? Anusha? Can we stop, Anusha? Yeah, so there are few questions which I would like to discuss. Are the so for example, this is one question where there is an emergency buzzer which has been activated for shoulder dystocia, and there are two instructing junior midwives to assist you in delivery with the macroburst in manure. So they are asking what is the macroburst manure. So as we discussed, it is hyperflexing and abducting the maternal thighs on the abdomen. So that is called as the macroburst manure, where it will increase the lumbosacral angle and increase the anteroposterior diameter of the pelvis and will straighten the lumbosacral angle. So that is the macroburst maneuver, which is usually successful in 90% of the cases. Then the next question is a woman who is type 2 diabetic is admitted for induction of labor at 38 weeks in her third pregnancy, and she had two previous spontaneous normal births. So she has epidural analgesia for pain relief and her labor is uncomplicated. So, but after the head is delivered, so that she is diagnosed with shoulder dystocia, and the baby's head cannot be delivered with axial traction and the macroburst or suprapubic pressure, meaning that it has been failed. So, what is the next appropriate subsequent step? So, as we saw from the algorithm, so either after giving an episiotomy, either the delivery of the posterior arm should be tried, or the or the doing any internal rotational maneuver should be tried. So here the option is correct answer is delivery of the posterior arm. Okay. So if there is elective cesarean section is best recommended to prevent morbidity from shoulder dystocia in which of the clinical situations. So elective cesarean section is best recommended when, especially if there is a suspected macrosomia in a case of a diabetic woman. For them, elective cesarean section will prevent morbidity from shoulder dystocia because, as I said, in diabetic women due to hyperinsulinemia, there is increased deposition of the fat around the shoulders, and hence there is increased risk of shoulder dystocia in them. So doing an elective cesarean section, if the baby's weight is more than 4.5 kilograms, will prevent morbidity from shoulder dystocia. So regarding shoulder dystocia, which of the following statements is true? So here, so the majority of the so it is a notion that the big baby will have shoulder dystocia. So the majority of the babies who have shoulder dystocia are not more than 4.5 kilos. They are less than 4.5 kilos. So in, and those who are more than 4.5 kilos, they majority of those babies do not develop shoulder dystocia. So that is only by the conventional risk factors which we had seen, the pre-labor and the intrapartum will only predict 16% of the cases of shoulder dystocia. So proper anticipation is needed. So as we saw that most of the babies are less than 4.5 kilos. So proper anticipation is important, and knowing the risk factors is very important. So this is a 35-year-old woman who is 33 weeks pregnant in her first pregnancy. So she has a 1-day history of headache and blood vision, and her blood pressure is 180 by 110. So it is severe preeclampsia, and her urine analysis shows 3 plus protein. So 1 week prior, her blood pressure was 120 by 70, and she had no proteinuria. So what is the most appropriate management in her? So we can see that she is a case of a severe preeclampsia because her blood pressure was normal before up to 32 weeks, meaning that her blood pressure has increased after 20 weeks. So it is a case of gestational hypertension, and plus she has proteinuria, and she is also having a blood vision, meaning that she is having some systemic problems. So that's why she's a case of severe preeclampsia. So, and also if she is having signs of imminent eclampsia like headache, blurring of vision, then the most important step in her management is to give intravenous magnesium sulfate because she is at high risk of developing an eclampsia. So, as I said, intravenous magnesium sulfate in the form of loading dose of 4 gram over 5 minutes and giving the infusion of 1 gram per hour for 24 hours is very important in this patient. And then controlling the blood pressure is very important. Thank you so much.